All right. Good morning, and thank you everyone for attending our DURB board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For DURB board members, please reserve the question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DURB board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meetings to help us improve our process moving forward. Thank you. And I see that Dr. Cannon is on. I will leave it to Dr. Cannon.
Good morning and thank you. Appreciate everybody getting up this morning. It was cold and dark and reminded me that it was no longer summer. So glad everyone could join us. We have a quorum, so we'll call this meeting to order. Everybody should have received the agenda. Noon, I was just looking and I don't see that I got a copy of the minutes. Did the minutes go out?
Yes, the minutes go out at the very first email that was sent, at least like several weeks ago.
Okay, so we'll go with that. Everybody should have received a copy of the minutes. Are there any questions or comments, changes that we need to discuss about the minutes? Hearing none, it's a good sign that you guys are ready to vote. Can I get a motion?
I move to approve the minutes.
Thank you, Dr. Siegfried. Do we have a second?
Second.
Thank you, Catherine. All right, all in favor? Aye.
Aye.
Any opposed? All right, the minutes are approved. So Noon, I'll turn it back to you. Do we have some housekeeping to take care of?
We don't have any housekeeping item for today. I think we do have a P&T update.
All right. So Brian.
Yes, in September, the P&T committee reviewed agents for hereditary angioedema, as well as we received our annual update from our accountable care organizations on their PDL methodologies. Next week, we will be reviewing agents for the treatment of Duchenne muscular dystrophy.
Right. Thank you, Brian. With that, let's just move into the meat of the agenda. So Stephanie is going to lead a discussion of Gaucher's disease. So we will turn the time over to her.
Good morning, everyone. So we'll be presenting a new PA. Can everyone see? Oh, there we go. Okay. So this is a PA. These 4 drugs used to be on our generic rare disease PA, and we put them into their own PA. I just wanted to give a little extra background since it's a rare disease, and most people are probably not familiar with it. So Gaucher disease is an autosomal recessive inborn error of metabolism. It results in the deficiency of an enzyme called glucocerebrosidase, which is in the lysosome of cells. The deficiency leads to the accumulation of glucocerebroside and other glycolipids in macrophage lysosomes. And then the macrophages accumulate in bone marrow, liver, spleen, and other tissues. The accumulation of the glucocerebroside in these lysosomes eventually causes the increase in levels of inflammatory mediators, This causes chronic inflammation, impaired healing, and fibrosis in multiple different tissues. Involves visceral organs, bone, and bone marrow in nearly all patients. There's also a significant range in the presentation of Gaucher disease. It can be anywhere from lethal soon after birth to asymptomatic into adulthood. So it really varies based on the enzyme activity. So the clinical manifestations, type 1 Gaucher disease, which I'm going to be mostly talking about because these 4 drugs are indicated for type 1 only, which is non-neuronopathic. Gaucher disease accounts for about 90% of cases. Clinical presentation usually includes anemia and thrombocytopenia. Consequently, a lot of patients experience fatigue if they're symptomatic. Osteoporosis and osteosclerosis is also pretty common, as is peripheral neuropathy. They can also experience enlargement and fibrosis in the spleen and liver, pulmonary hypertension, and delayed growth in puberty. This is diagnosed with a glucocerebrosidase enzyme activity assay most of the time. And then the 4 treatment options that will be on the PA include 2 different groups of medications. One is substrate reduction therapy, which is both are pretty self-explanatory. It reduces the accumulation of glycolipids by decreasing the synthesis of glucocerebroside. The medication that we'll be including from that category is aliglustat or Serdelga. The other 3 options are enzyme replacement therapy, which is pretty common with a lot of inborn errors of metabolism for treatment. And they are all recombinant glucocerebrosidase enzyme that allows the glucocerebroside to be broken down into glycosides and lipids so they don't accumulate in the lysosome. Those 3 are imglucerase, teleglucerase alpha, and velaglucerase alpha, known by the brand names as Cerezyme, Elelyso, and Vpriv. The substrate reduction therapy is an oral medication, and the enzyme replacement therapies are IV medications that are weight-based and given usually every other week. And so that's just the quick overview I wanted to give you all. Pull up the prior authorization. Sorry, it's deciding not to load this morning. Please let me know if you can't see the prior authorization form. So the general criteria are that the patient has a diagnosis of the type 1 non-neuronopathic Gaucher disease confirmed by enzyme testing, which is most likely, or gene sequencing, that the medications being prescribed by or in consultation with a specialist. There are multiple different types of specialists who could be involved in diagnosing and caring for these patients. So we decided to leave that criterion pretty general. And the third general criterion is, does the patient have symptomatic manifestations of Gaucher disease? We listed the examples of anemia, thrombocytopenia, bone disease, hepatomegaly, and splenomegaly. And we require this just because it is recommended that that the patient be symptomatic for treatment, since there are many patients who can remain asymptomatic and be healthy depending on the enzyme activity. The other criteria for the individual drugs are mostly age requirements that are in the FDA indication. For Serdelga, we also have the requirement of if the patient is a CYP2D6 intermediate or ultra-rapid metabolizer. That's because if they are an intermediate or ultra-rapid metabolizer, they will require 1 tablet twice a day dosing as opposed to 1 tablet once a day for a poor metabolizer. And for our reauthorization criteria, it's pretty general, as we ask for a lot of our reauthorization criteria on other PAs, just that there's documentation of a positive clinical response, including but not limited to an increase in hemoglobin and platelet levels, reduction in spleen and liver volumes, improvements in bone mineral density, and reduction in fatigue as they apply. Again, we wanted it to be a little more general because it can present differently in different patients. I didn't want to have more specific criteria that maybe applied to some patients and didn't apply to others. Initial authorization and reauthorization will be up to 6 months and up to a year, as we do with most of our prior authorizations. And that's all I have. The only thing in the notes is the boxed warning for the enzyme replacement therapies that are administered IV, and the risk for hypersensitivity and anaphylaxis upon administration.
All right. Are there any questions? Catherine, you get your hand up.
Yeah, I had two questions. First question is why Miglustat wasn't included in this prior authorization. And the second question was, I guess, why type 3 couldn't be considered as an off-label indication, because it's recommended by guidelines that you could treat type 3 as well.
So with Miglustat, we didn't initially include that because it was not one of the primary recommended therapies. And it is an older drug. We can definitely include that on here with the same individual criteria as you see with the other drugs. It's just our impression when looking at this disease state is that it's very rarely used because they have newer, more effective medications. And it's also indicated for Pompe disease as well. So that was going to be included on that prior auth form. Again, we can definitely add that to this prior auth form. And as far as the type 3 Gaucher disease, we do have our off-label criteria that they can meet and that we can consider for approval if they submit it for any of these drugs too.
All right. And any other questions? And if not, we'll go to public comment. And looks like we have someone from Sanofi, and I will probably mispronounce this, but Jia Feng.
It's Jai. Good morning.
Good morning.
Let me grab my statement. So hello, everyone. My name is Jai Feng. I'm the Medical and Scientific Associate Director for Gaucher disease at Sanofi. And I hope that after this conversation, we'll continue to allow Cerezyme and Xerdava access to Utah patients with Gaucher disease. So as was stated, Cerezyme or imiglucerase was initially approved in 1994 as an enzyme replacement therapy indicated for the treatment of adults and pediatric patients 2 years of age and older with type 1 Gaucher disease that results in anemia, thrombocytopenia, bone disease, hepatomegaly, and or splenomegaly. The way it works, it catalyzes the hydrolysis of excess GL1 to glucose and ceramide, as was stated. It is administered as an intravenous infusion. The recommended dosage is actually based on disease severity. It can range from 2.5 units per kilogram every 3 times a week to 60 units per kilogram every 2 weeks. And that dose really should be titrated based on the clinical manifestations and the therapeutic goals of each individual patient. Clinically significant responses to Cerezyme have been observed within 6 months of treatment initiation. Longer-term symptom improvement continued to be observed at 2 to 5 years and were maintained at 10 years and even 20 years of treatment for both the non-splenectomized and splenectomized patients. And regardless of pretreatment disease severity, Cerezyme treatment positively affected the skeletal symptoms, as noted by decreased bone pain and bone crisis, and increased bone mineral density, as well as decreased risk of osteonecrosis. As stated, the patients treated with Cerezyme have experienced life-threatening hypersensitive reactions, including anaphylaxis, which again is listed as a box warning on our package insert. Approximately 15% of patients who've been treated have developed IgG antibodies to Cerezyme within the first year of therapy. And adverse reactions reported in adults include back pain, chills, dizziness, fatigue, headache, hypersensitivity reactions, nausea, pyrexia, and vomiting. And the adverse reactions in pediatric patients are similar to those seen in adults. Additionally, In 2014, the FDA approved Serdug or alaglustat as the only first-line oral therapy indicated for the long-term treatment of adults with Gaucher disease type 1 who are, as again stated, CYP2D6 extensive, intermediate, or poor metabolizers. And as we discussed, Serdug does act as a substrate reduction therapy for Gaucher disease type 1 by reducing that production of glucose riboside and thus alleviating the accumulation of GL1 in the target organs. The dosing and the management of drug-drug interactions is dependent on the patient's metabolizer status, and it's not recommended in patients who have pre-existing cardiac disease or for patients who are taking certain concomitant medications. In our clinical studies, in our phase 3 randomized placebo-controlled trial of 40 naive Gaucher type 1 patients, Serdug did significantly improve hepatosplenomegaly as well as anemia and thrombocytopenia compared to placebo. And during the long-term open-label extension period, significant improvements were also seen in patients who were originally placed on placebo for those first 9 months. Incremental improvements were also seen in patients out to 4.5 years. In a second phase 3 study of 160 patients at 1 year, Serdug did meet criteria for non-inferiority to Cerezyme in adult Gaucher type 1 patients who were previously stabilized on enzyme replacement therapy. And patients in the long-term extension period continue to show stability in the same disease parameter out to 4 years. Common adverse reactions to Serdug include fatigue, headache, nausea, diarrhea, back pain, pain in extremities, and upper abdominal pain. Thank you so much for this opportunity to provide some data on Cerezyme and Serdug. And again, we hope that you will continue to allow access to both these therapeutic options to patients in who have Gaucher disease in Utah.
You are muted, Eric.
Oh, just having a conversation with myself. That happens all day long here. Thank you. We appreciate you taking the time to convey your thoughts and represent Sanofi. Moving on for the committee, are there any recommendations that we have on this prior authorization? Dr. Smith.
Can you scroll up, I think, a little bit on this prior auth? Sorry, not up, down. There's like a list of, sorry, scroll back a little bit more.
Okay.
It's the list of symptoms.
Up top.
Just right there.
This one.
Yeah, I was wondering if IE can be changed to an EG for anemia, thrombocytopenia, bone disease.
Thank you.
I had one more thing, which was as I initially read this, it sounded like the 2D6 was like a disqualifier as opposed to just something you need for dosing. I was wondering if it might be more clear if the wording just said, is the patient's 2D6 metabolism status known or has it been obtained? Does that make sense?
Yeah, and I can reword that too, to clarify that it's for dosing as well. We just asked specifically for that because it changes what dose we would approve. So I'll make sure to reword that so it's clear that it's just we need it for the dosing.
Sounds good.
Other comments from the committee? All right, hearing none, do we have a motion to approve this recommendation?
Motion to approve.
Thank you, Sam. Do we have a second?
Second.
Thank you, Dr. Britton. I have a motion and a second. All in favor? Aye.
Aye.
Any opposed? All right. Motion carries. The department will move forward with implementing this criteria. So with that, moving on, I think, Luis, we have you talking about DURB that's used for Rett syndrome.
Hello, everyone. Let me see if I can get this to the presenter's view. Okay. All right. So hello, everyone. Yes, like Eric said, I'll be presenting on Rett syndrome and DURB. And there's the agenda. So Rett syndrome is a rare genetic neurodevelopmental disorder, and it has specific characteristics here, including that the symptoms appear around the age of 18 months, followed by clinical regression between ages 1 and 4 years. And it is characterized by typical early growth and development, followed by slowing of development, loss of function of the hands, unusual hand movements, slowed brain and head growth, problems with walking, seizures, and intellectual disability. Additionally, it can also affect the GI tract. And so patients typically have problems with feeding and digestion issues. And then also controlling eye movement and sleep disorders. So it's definitely a disease that affects the whole person. It is more prevalent in girls compared to boys. And although it can also happen in boys, most cases are caused by a mutation in the metal CpG binding protein 2, or MECP2 gene, which is responsible for the synthesis of the MECP2 protein, which is a regulatory protein in the brain that functions with the brain development. There is no cure at this time, but a new treatment is available for children aged 2 years and above. And also, a treatment also involves supportive care, depending on the symptoms that the patient is exhibiting. Let's see here. Okay, my slide isn't, oh, there it is. Okay, so now let's talk about DAYBUE, trofinetide, which is the first FDA-approved therapy for the treatment of RTT. Mechanism of action is unknown, but it is proposed that it works by reducing neuroinflammation, inhibiting production of inflammatory cytokines, and the overactivation of microglia and astrocytes, and supporting synaptic function. And it is a synthetic analog of the glycine proline glutamate, the N-terminal tripeptide of insulin-like growth factor, IGF-1. It is available as an oral solution. It is dosed twice daily, and it is weight-based dosing. There's the common side effects, mainly involving the GI tract. And here's the Lavender study, which is the main study that evaluated DAYBUE. It was a 12-week randomized double-blind placebo-controlled study. And it included 187 female patients with Rett syndrome aged 5 to 20 years of age. And the co-primary endpoints included improvement in the Rett syndrome behavior questionnaire, which that is a tool that is used, it is administered by the caregiver. And then also the Clinical Global Impression Improvement, or CGI assessment, which that one is administered by the provider. And so here. All right, and then the study results. So the statistically significant improvement was observed in the Rett syndrome behavior questionnaire, and also in the CGI, with points, improvement by 3 or so points. But given that this is the only treatment available for RTT, it is quite significant when it showed those improvements. And there are the references, and now I'm going to share the actual PA form. Let me know if you can see it. Okay. All right. So, Dave, here's the criteria. So it's for patients at least two years of age or older. And then it does require that the diagnosis be confirmed through the generic testing for mutations in the MECP2 gene. It is we require that it is prescribed in consultation with the neurologist. However, we are open if the DURB board also wishes to include other specialists. So, for example, developmental pediatrician could also be a specialist and a geneticist that usually diagnoses RTT. And number 4 here, does the patient meet all of the following diagnostic criteria for RTT with a period of regression followed by a period of recovery or stabilization? So partial or complete loss of acquired personal hand skills, partial or complete loss of spoken language, gait abnormalities, stereotypic hand movements such as hand wiggling, squeezing, clapping, tapping, mouthing, and washing or rubbing automatisms. So those are the classic, symptoms there. Does the patient have a clinical global impression improvement CGI score of greater than or equal to 4? And that was part of the inclusion criteria for the study. And it was also recommended by the ACOs to include in the PA form. Reauthorization criteria has the provider send an updated letter with medical justification or updated chart notes showing that the patient has had clinically significant improvement as measured by an improved CGI score. And the initial authorization is up to 3 months, reauthorization up to 1 year. And here are some notes here for the provider, just being that the main side effect for this medication is diarrhea. There's some information here on that. And that is all for the PA criteria.
Dr. Britton, your hand up.
Thanks so much, Luis, for this. I just had a question. So is this therapy just used temporarily then? Is it just a 1 to 2 year therapy and that's the lifetime use of it? Or is it something that people continue to need?
No, it's something that the patients continue to need as the disease, patients usually have to, they can, go past their adolescence years with this condition. And so, yes, it is a lifelong therapy as far as I know.
Does that renewal of the 1 year, like, is that pretty standard? And after the 1 year, there's another 1 year renewal they could do?
Yes, that is pretty standard. I've seen that in different PA forms by other insurance companies.
Right. It doesn't limit it to just 1 year and then a renewal year. That still opens up to all the years they might need.
Correct.
Okay. And then I don't know if this is the time to mention this or not, but I do like your idea up with the neurologist about including developmental pediatricians and geneticists, that kind of idea. I know my patients with Rett syndrome are often followed a lot more by those folks than they are by the neurologist, since they don't have a lot of other things neurologists follow. But I don't know if there needs to be language to broaden that to other, complex care docs. I mean, I guess there's a group of docs that might be, should it be maybe something that's not restricted, like specialists including, neurologists or geneticists or developmental pediatricians, like versus something that's restricted. What do you guys think?
Yeah, I think we can. I think that's a great recommendation, and I think let's make sure we don't have any more questions for Luis, and then we'll go to public comment. And then we can come back and kind of fine tune the form. Catherine.
So when I was reading about this, I guess there are people who can also present with atypical Rett syndrome where they don't have they're not positive for the mutation in the MECP2 gene, and they don't meet all of these diagnostic criteria. I guess my question is, we want to exclude them or maybe loosen the wording to include them? I know they were not part of the lavender trial, just FYI.
Correct. Yes. What I presented is more the classical Rett syndrome presentation, but the atypical Rett syndrome also includes, that's with symptoms that may start as the child is a newborn, and there's other like Dr. Smith said, other generic variants in atypical forms, and so, but you're right, these were not included in the study. And so that's why we feel like just sticking with the classic. But I would also like to know your opinions.
All right. Any other questions? All right. We've got a list of people for comments. So is Mandy Champ here from Acadia?
Hi, can you hear me?
Yes, we can.
Oh, wonderful. Thank you. Good morning. My name is Mandy Champ, and I'm a managed care pharmacist in medical affairs at Acadia Pharmaceuticals. DAYBUE or trofinetide is the first and only FDA-approved treatment for Rett syndrome in adults and pediatric patients 2 years of age and older. Thank you so much for the opportunity to provide you with information on DAYBUE and Rett syndrome. Like Louise said, Rett syndrome is a rare, severe genetic neurodevelopmental disorder that affects approximately 6,000 to 9,000 people in the United States. Individuals with Rett syndrome require lifelong continuous care and assistance with aspects of daily living. Historic approaches to the management of Rett syndrome have not been specific to the disorder. And Rett syndrome is diagnosed via clinical evaluation as early as 18 months of age. However, confirmatory genetic testing is not mandatory for Rett syndrome diagnosis and clinical practice. Like Louise said, it was included in clinical trials to determine the presence and type of underlying mutations, but again, it's not used in clinical practice to diagnose Rett syndrome. Analysis shows that 19 to 23% of individuals with Rett syndrome are not identifiable through genetic testing. Also, given that Rett syndrome is a rare disorder and may be difficult for patients to access a Rett syndrome center of excellence or specialist, many Rett patients rely on multiple providers to manage their many comorbidities. The efficacy of trofinetide was established in Lavender, like Louise said, which is a 12-week phase 3 double-blind placebo-controlled trial in female patients 5 to 20 years of age with Rett syndrome. Patients with Rett syndrome treated with trofinetide achieved a statistically significant difference in favor of trofinetide as compared to placebo in both of the co-primary endpoints. One is measured by a clinical trial tool from the caregiver perspective called RSVQ, and the second from the provider perspective called the CGI-I. Both achieved a clinically significant difference. And these clinical trial tools are not intended for use in clinical practice. The long-term efficacy and safety of DAYBUE have also been evaluated in open-label extension studies going out to over 3 years. Notable adverse reactions reported in the 12-week Lavender study were diarrhea, vomiting, fever, seizure, anxiety, decreased appetite, fatigue, and nasopharyngitis. The label includes warnings and precautions related to diarrhea, weight loss, and vomiting. For additional information, you can refer to the PI. In closing, DAYBUE is the first and only therapy approved by the FDA for the treatment of Rett syndrome, and this treatment can help address unmet medical needs for these patients. Another thing that I did want to mention after seeing that your criteria was that CGI-I is a clinical global impression improvement score, and it's not done at baseline. It's used to show the improvement that patients have made on therapy. So that doesn't make sense to do right at the beginning of treatment with DAYBUE. Acadia respectfully requests that Utah Medicaid allow access to DAYBUE so that indicated patients, including atypical and typical DAYBUE patients or Rett patients with Rett syndrome, can appropriately obtain this FDA-approved treatment. Thank you so much for your time and attention. If you have any questions, I'm available for those.
Thank you, Mandy. Any questions?
Yeah, thank you.
Mandy? All right, we have two additional people to comment. I'd remind you that Brian Larson is timing and we limit comments to 3 minutes. So Brittany Moreno, are you present?
Hi, yes.
All right, we'll turn some time over to you.
Hey, perfect. Well, I am no specialist or doctor or company. I'm just a mom who has a daughter with Rett syndrome. So for us, our daughter's name is Camilla, and she is 2 years old, turning 3 in about a week. She has all these things that are listed. She's lost her head movement. She never spoke. She never walked, anything like that. So when we first heard about Debut, it was at a conference this past summer, and we were actually able to sit down and meet with Acadia and some reps there, and we figured that we would give it a go. So we started Debut in August, and it hasn't even been that long, and we're already seeing so many improvements in our daughter. Her left hand she had lost all gripping, anything like that, and now she can actually like hold things for a couple of seconds. She seems to be a lot more aware. She uses an eye gaze machine now, and she likes to sit there and play games and talk to you, and she's just overall happy. And it's only been 4 months. So for us, Debut has widely given us back life in our daughter, I guess you could say. For us, Debut was a no-brainer. I mean, it's something that you can stop at any point. So we decided to go ahead and give it a go. Like they listed the side effects, our daughter has GI problems, which she actually can't go to the bathroom. So Debut only helps her. So we stopped all lactulose, like it said, and Debut is the thing that actually gets her to go to the bathroom. So for us, we haven't seen any side effects with it. I know it hasn't been that long, but for us, I would say Debut has just, again, given us so much back from our daughter, and she's a lot happier. She's a lot more aware. Her hand movement's coming back. Obviously, she's in all the therapies as well, so that probably plays a part into it. But since being on Debut, I can say that it's been a life changer for us. So just wanted to share my experience and hope that this stays approved here in Utah.
Thank you, Brittany. We appreciate you taking a few minutes and are very happy to hear that your daughter's improving a little bit, and wish you the very best. Anna Dance, are you present?
I am. I think my Google name's Swanky, but I'm really Anna Dance. Thank you so much. My name is Anna Dance Heimberger, and it's an opportunity to speak to you about Rett syndrome and the drug Debut. My daughter Lucy, who hopefully you see in this picture, is 16 and suffers from Rett syndrome, which is a devastating genetic disease, which you have heard, that affects multiple body functions. It creates seizures, GI issues, bone density issues, and it deprives them of verbal speech, body control, social engagements, and oh, so much more. Normally, I stand before groups and talk about all the wonderful things that Lucy can do and has achieved with help. And I share moments of triumph, of joy, and the deep love our family has for each other. But today, I want to peel back those protective layers that we project to the world and share the real and struggling on daily onset of Rett syndrome. Lucy is our youngest child. She was born perfect, and we were eager to welcome a baby girl into our lives. Everything seemed fine until about a year or 18 months when she stopped hitting milestones. We reached out to the medical community, and after many tests, got results that Lucy had Rett syndrome. We had never heard of this, and I wish to this day I never had. As time progressed and Rett took hold of her body, Rett syndrome robbed Lucy of the ability to walk, to talk, to use her hands. She was in pain and she cried often. She lost weight and couldn't tolerate groups. Fast forward to her being 16 and things have only gotten worse. Her legs and arms were not straightened due to contractures of being in a wheelchair. She's isolated and it's hard to make friends. She spends most hours outside of school in therapy. She wears pull-ups. She relies on us to feed and hydrate her, which takes about 4 hours a day. And most recently, she started to have seizures. She's aware of all that she cannot do and due to this, her mood is very somber. Rhett continues to change everything in our lives, and especially in Lucy's. We travel to California each year to a Rhett specialty clinic for help in knowing how to treat and live with Rhett. And last year on our visit, we were presented with our first ray of hope, a new FDA drug for Rhett called DURB. It was the first of its kind. This new drug has the ability to give Rhett individuals portions of their lives back, like Brittany has spoken. Most report being happier, more focused. Some have started using their hands, making greater strides in therapies, developing friends, and some are even saying their first words. This is a miraculous dream come true. We want all Rhett individuals in Utah to be able to have access to DURB to see if it can enhance their lives. For me, I just one day long to hear my daughter say, "Mom." Thanks for listening.
Thank you, Anna. We appreciate that, and are excited that Lucy was able to find something that may be able to help her. So thank you for taking a little time today. We appreciate both you and Brittany joining us. Turning back to the committee, we've had a few discussions about the form, broadening the number of specialists or those who can prescribe the drug. Are there other thoughts, comments from the committee? Jordan, you got your hand up.
Yeah, I think it was already mentioned, but in addition, broadening that criteria to Rett syndrome, because it sounds like any atypical and doesn't have to have the genetic marker, because it sounds like there are several, lots of patients that could qualify to get support with this medication, but that kind of limits who would be able to get it.
All right. Dr. Siegfried?
Yes, number 5, actually, as pointed out by the drug company representative, it is not a measure used at baseline. It's actually the Clinical Global Impression Severity Score. If you use a CGI improvement score of greater than or equal to 4 at baseline, that means either no improvement with therapy or worsening of improvement from baseline, which is something that you measure after implementing a treatment, not at baseline, if that makes sense. It's unclear why they would use the improvement score as part of the entry criteria into the drug trial instead of a severity score. It would be meaningful to have a Clinical Global Impression improvement score decrease to less than or equal to 4 after receiving the drug for a period of time.
So for a reauthorization criteria.
Reauthorization, yes.
Okay. All right. Dr. Smith? We had Catherine. We lost Catherine.
She's muted. Catherine's muted.
Sorry about that. The lavender trial inclusion criteria, it does say severity score. It doesn't say improvement score. So can we change number 5 to say severity score for if the goal here is to match the clinical trial inclusion criteria?
Yes, that makes sense. Thank you for pointing that out.
And can I just add that if we don't loosen the criteria for this to include atypical, can we re-review this in maybe 6 months, a year, and consider including atypical?
As far as I understand too, the classical RTT is rare, and the atypical is even more rare.
Mhm.
And so I don't know how much it would impact,
May just be nice to maybe even have some case reports to look at, something.
Yeah, Luis, if we could come back, say in 6 months and see if you've had requests for the atypical, I think,
Mm.
you all still have your medical exception process, so that as,
Right.
during review, if you needed to, you could move ahead and approve that. I think that's a good idea. Thank you, Catherine. All right. Sam?
I'm just wondering, for the reauthorization, when we having clinically significant improvement, is that going to include a specific improvement in CGI as well? Like a number, is there a specific number we're looking at that we should include?
I think Dr. Siegfried recommended, if it's less than 4 as an appropriate improvement score.
Okay.
That's correct.
Okay, because it looks like less than 40% had improvement. So I think that'd be definitely important to include something specific in that for reauthorization. Excuse me, I'm a little sick, so my voice sounds a little bad.
You may want to look at the original study, and it may be less than or equal to 4, or less than 4. I don't immediately have access to the study itself.
Thank you, Dr. Siegfried.
All right. Other thoughts?
Yes, if I may, just the typing essentially. So we're going to change 5 on the initial authorization to include the severity. So I would spell that out and with the abbreviation, and then under the reauthorization, if we're going to use the CGI, just spell that out. So it's clear we've got the 2 different tools and where they belong in the sequence.
Perfect.
Thank you.
All right. Do you guys want Luis to make the changes and bring the form back to us next month just for a quick follow up and sign off to make sure it came out the way you want?
Yes, thank you.
Okay. All right. Dr. Britton?
Yeah, and then just to on citing on language with the neurologists, since neurologists really follow some of the symptoms of Rett's, don't do all of the symptoms, either making it, an inclusive statement, something like a specialist neurology, developmental, et cetera, or having it be a recommended thing versus a required thing.
Noted. Thank you, Dr. Brinton.
All right. There's no other thoughts. Thank you, everyone, for taking your time to go through that. Definitely a devastating disease that, while the treatment may not be the world's most effective, it is something that offers hope, and I think that's truly important that we have a criteria that allows an opportunity for people to at least make sure it works or it doesn't work for them. So that is everything we had on the agenda today.
We do have one more prior, Eric. Dr. Cannon, is methadone.
Oh, I'm not turning the page. I apologize. We don't normally get to go to 2 pages. All right, let's talk about methadone. I was so excited. It was just like a little after 8 and we were going home.
Okay, so here's the methadone revised PA form, which was revised to include a yes/no type questions for our decision tree. And so there's been a few changes here, so I'm just going to go through it. So number 1, we wanted to make it clear that it is for patients that have intractable pain associated with active cancer or palliative care. If that is marked correctly or yes, then that's all they need to do on this form after they sign and submit. And then the patient has to be 18 years of age or older. It's a patient, an infant discharged from the hospital on a methadone taper, less than 1 year of age. Does the patient have contraindication to all other long-acting opioids? Is the patient currently taking any of the following? Just looking for things that could further increase the risk of side effects. Does the patient receive buprenorphine, naltrexone, or combination thereof concurrently? Is the patient taking methadone for the treatment of chronic pain only? Because if they're taking it for assisted, for treatment of OUD and things, then that goes through a different route. Has the prescriber checked the controlled substance database? Reiterating, encouraging prescribers to do that every time to make sure that there's no dangerous combinations. For prescriptions above 50 MME per day and are taking with dangerous combinations, has the prescriber attesting to offer naloxone to the patient. And we also emphasize that naloxone nasal spray does not require prior authorization. Does the prescriber attest a treatment plan outlining goals that address the benefits and harms as has been established with the patient, including each of the following bullets, along with a signed agreement with the patient? So just to make sure that the patient and the provider are talking about important points in terms of goals and education on side effects and things like that they can attest to. Has the prescriber completed a urine drug screen? So this is new compared to our previous form. So we want the prescriber to do a urine drug screen at least annually and to attach a copy of the most recent one. Can the prescriber attest to assessing the following FDA black box warnings? And then the reauth criteria is improvement, any sign of improvement as shown by specific appropriate monitoring parameters or improvement in symptoms. Initial authorization up to 3 months and a reauthorization up to 6 months. And here's the point that I was trying to make earlier. Methadone use for the treatment of opioid use disorder should be administered through a treatment facility and billed through the medical benefits as part of comprehensive MAT. So
Sam, we see a hand up, and then we'll go after you. We'll go to Dr. Weinstein.
Okay, thank you. A couple of things on this. So going on to the first page, number 9, there are other products besides naloxone. So I think that language needs to be more agnostic to include opioid overdose reversal agent or something to that effect. Just so that as new products also come out, it covers that. And then down below on the note section, the terminology MAT for medication assisted treatment is outdated, and in efforts to destigmatize this disease state, different terminology should be used, whether it's treatment for opioid use disorder or MOUD. Those are more acceptable terms. So if we can change MAT to one of those, that'd be great.
thank you, Sam.
All right, Dr. Weinstein?
Yes, thank you. So I think we all understand why methadone is authorized separately from other opioid agonist drugs. Some of you may have been working in the field in the early 2000s when the use of methadone was promoted widely in primary care as a treatment for pain, and there was a series of deaths associated with methadone overdose that occurred after a week or two of treatment. And when we dug into that, it appeared that the prescribers really were not familiar with the unique pharmacokinetics of methadone. So methadone has quite variable metabolism in people, and the half-life can be short or pretty long, maybe even up to 120 hours last I trained. So I think we have reasons to be concerned. This is a very cheap drug, and has advantages that way for cost effectiveness, but it's tricky to use if you're not aware of some of its unique characteristics. It also is unique among agonists with having the cardiac toxicity. Number 4 that you have displayed now, technically, methadone is not a long-acting analgesic, right? It's a drug with variable half-life and maybe long-acting for methadone maintenance for opioid use disorder. But I'm not quite sure why we're saying that we would have a patient have contraindication to all other available long-acting analgesic opioids before going to this. So if there's some background on that, that's a question. And do we have, again, we would recommend, in addition to the urine drug screens, an annual cardiogram because of the unique toxicities. So that's a recommendation.
Thank you for that observation, Dr. Weinstein. So, yeah, I agree to include an attestation for an annual cardiogram in addition to the urine drug screen. In terms of the question for number 4, I believe we were mostly thinking that when methadone is used for pain, I guess it is more on the long-acting opioid side compared to the immediate acting opioids. And so, but you're right in terms of, how it can affect someone and with the metabolism of the patient. And so that is not considered long-acting.
So for number 4, just thinking practically, then you would want a patient to have a documented contraindication to long-acting morphine, long-acting oxycodone, transdermal fentanyl. Is that the stepwise drug therapy that we're recommending here? That we wouldn't use methadone in somebody until they have had a contraindication to transdermal fentanyl? I mean, clinically, I don't think that's correct. That's why I'm asking.
Yeah, I think that's what we were aiming for, just because of the how dangerous methadone can be because of its metabolism profile.
But if I recall, this has a dose limit outside of treating sickle pain, terminal pain, for chronic non-terminal pain, and outside of sickle cell, you have a dose limit of 20 milligrams a day. So I don't think the toxicity at that level again, this is just clinical experience, why we would put a low dose of methadone after transdermal fentanyl. Again, it's a clinical question.
Yeah, so it probably, makes sense maybe to exclude this number 4, just because we already have a limit in place.
And I think there might be something to say here about the prescriber. I don't know whether, I mean, in looking at other pre-auth forms, I don't think we have, except for indicating specialists, something that the prescriber attests to having familiarity with the unique pharmacokinetic characteristics of this drug, like they attest to that they know what they're doing. I'm sorry, I don't mean to sound that way, but this is the unique, risk of this drug. Again, I'm not as concerned with the lower dose, with the monitoring things in place, and with the potential, for drug interactions with some of the other medicines. But in practice, we sometimes do use methadone like other long-acting opioids on a schedule, and then give some short-acting on top of it. Again, this gets into pain medicine. So if this is really directed at the non-specialist, then my long way around of asking, do we want to have something in here that the prescriber attests to some familiarity, or they've consulted with somebody who has that expertise? I guess that's where I end on that thought. Thank you.
All right, Catherine, we've got you and then Dr. Siegfried. And time check, we're getting down into the final minutes today.
I guess I'm looking at the one about number 3, infant discharge from the hospital on a methadone taper. That to me would seem kind of like a carve out, kind of like the first one, because the stuff about 18 years and older and, treating pain, none of that would apply in that case. So I don't know if that one should also have a yes, no, if yes, please sign and submit kind of thing.
Good point.
You could just add 3 to 1.
Yeah, except you'd have to change the intractable pain, I guess you could say, or neonatal abstinence syndrome, unless it's iatrogenic withdrawal, I guess. Either way.
Yeah, thank you for noting that.
All right, Dr. Siegfried.
I just wanted to briefly comment on number 4 with Dr. Weinstein, that sometimes we do use methadone for neuropathic pain. It seems to have some properties that seem to benefit neuropathic pain more than some other opioids. And then in number 5, I wanted to ask Dr. Weinstein if we should include gabapentinoids, given more recent evidence that they also may cause significant respiratory depression.
It's a good pickup. Be hard to put a long list of all of the sedative hypnotics that would potentially compound respiratory depression from agonists or methadone therapy. So, but I think it is a good recommendation. Yes, since the data are there for the gabapentinoids.
Thank you.
Other comments? All right, Louise, this one sounds like it gets the same treatment the last one did. So if we can clean both of these up and bring them back, and we can get them out to the committee beforehand, that would be good. And when you get these, if there's a change that we discussed that didn't make it in there, will you email back with Luis and let's see if we can't get the form updated before we get to the committee next month? Thank you. Dr. Breton.
I just wanted to thank you guys. I feel like everyone has been so thorough digging into these issues here and looking at the data, and grateful for Luis's work and for Stephanie's work, and just really appreciate you guys as colleagues. I think we're doing a really good job meeting the needs of Utah, patients in a safe way. So thank you.
No, thank you. We really appreciate that. And I think it is a great credit to this group and the commitment they make to be here every month. And I mean, the compensation is really good, so I know that drives a lot of you. Thank you for being here. On that lovely note, do we have a motion to adjourn?
Move to adjourn.
Dr. Weinstein has moved to adjourn and Sam has provided a second. And so we don't even need to vote on that one. We'll just all hang up. Thanks, everybody. We'll see you next month.
Have a great day.
Bye. Bye.